I had a blast at this morning's Q&A. Unfortunately, I didn't get to answer all the questions. That's what this video is for. In this after-party video, I'm going to answer as many of the unanswered live questions as possible. Stay tuned, because that starts right now. Howdy. Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits. And it's my hope that through these videos, I can help you learn too. This morning, I had a blast doing a live Q&A, Ask Me Anything Multiple Sclerosis. There were almost 100 folks that jumped online early this morning on Saturday, and I really enjoyed answering your questions. Unfortunately, I couldn't get to all of them during the live feed. I've gone back and picked out key awesome questions, grouped them based on topic, and I'm going to answer them in this video. So let's jump in. Aisha Simpson writes, my neuro said there has been a few cases of Lemtrada causing problems with liver. Do you know anything about that? Yes. There was a very recent label update, I'm talking just within the last week or two, that shared that there's been several cases of autoimmune hepatitis. Now, this is an autoimmunity that can affect the liver. And so there's going to be an increase in liver screening moving forward so we can catch these cases. The good news is it is rare and it's something that we can monitor with simple laboratories. Phantom Messenger asks, Lemtrada versus Cladribine, why one over the other? Now that is an amazingly large question, and it'll be the topic of an upcoming video that I'm planning. So stay tuned when I dive into Cladribine and my thoughts of Cladribine and Lemtrada. Sonia Ahmed writes, I'm not taking any DMT for MS. I'm thinking it is dangerous not to treat MS at all with any drug. Now, I have a very biased opinion. I am much more concerned about MS untreated or MS undertreated than I am about the side effects of a given drug. It's my strong opinion that the cost benefit of these therapies far outweigh the risks of untreated MS. That's my very strong but biased opinion. And I hope that you can find a therapy that you are comfortable with to keep yourself safe and to protect your brain as you age and live with multiple sclerosis. Judith Iserwood writes, hi, Dr. B. From very hot southern Australia. Wow, I'm jealous. Is Ocrevus effective in late onset MS? Now, when people talk about late onset MS, typically they're talking about MS diagnosed after the age of 40 or symptom onset after the age of 40. And if that's what you mean, Judith, the answer is yes. Alternatively, one might interpret the question to suggest, what about people that have had MS for a long time or they're of an older age? And my answer is still yes. There is some literature suggesting that MS drugs might work less well in older people, chronologic age, as compared to younger people with chronologic age, but that doesn't mean it doesn't work. And there's enough evidence, preliminarily at least, that Ocrevus can maintain hand function, maintain cognition, slow disability in progressive disease states, and slow brain shrinkage in progressive disease states, that I think that it's valuable to use the medicine. That's my opinion. Nalia Large asks, is it true that once you've taken third-tier medicines, i.e. Tysabri, that you can't go back to other drugs? No, that's not true. It does not close a door. Now, I'll share with you that normally when we escalate to a medicine like Tysabri, we're doing it for a reason, and oftentimes it's because of breakthrough disease activity. And so oftentimes when we're there, we don't want to go backwards to medicines that we think might not be as effective. But it's not as if a door closed and we're not allowed. It's not as if it's suddenly terribly not safe. It is something that one might need to do. Jennifer asks, what is plasmapheresis? And Jennifer, that's an excellent question. Plasmapheresis is a treatment for acute MS attacks, and it's not a drug, it's a procedure. To speak about it plainly, you put in large bore IVs into a person, typically in their neck, although sometimes you can do it in other parts of the body. And you take some of the red blood out, you clean it, and you put it back. And essentially what you're doing is you're pulling off the naughty autoantibodies in their body that are attacking them, and then you're putting back blood without those autoantibodies in them. And we use pheresis as a second line when people have had a devastating MS attack. Let's say, for example, they've had an MS attack where they can't use their legs. We give them steroids and they don't recover. Then we'll use pheresis as a second line therapy. Pheresis is used very frequently in a cousin of MS, neuromyelitis optica, or NMO. Pheresis is oftentimes done in the inpatient setting in the hospital. I'm very proud that at our infusion center, we can actually do pheresis for patients as an outpatient, so they don't have to be admitted to the hospital. They just come and have their pheresis done in the outpatient infusion environment. Tina Ross writes, "I have no insurance, so I can't get any help." False. Tina, I hope you're listening because that's not true. In my entire career, the only people that haven't had access to care are those that won't come and see us. There are clinical trials where people with MS are assigned to take a real drug or a different real drug. Everybody's on treatment, and they just don't know which one it is. And those trials pay for all the care, the doctor's visits, the cost of the drugs, the cost of the MRIs, the cost of the labs. That's one way that you can achieve a very high level of tertiary care in the context of a trial where you know you're not on a fake drug. But you don't have to go into a trial to be cared for. There are government assistance programs, and there are patient programs that hospital systems have, and there are assistance programs from manufacturers. So I implore you, seek out an MS doctor, or seek out a primary care doctor, or call and ask about a clinical trial. There are ways to be treated even if you don't have access to insurance. That should not be a barrier. Vicky Knox writes, "I'm seeing a new neurologist on the 6th due to insurance change. Bummer, I now have an HMO. Do you have any ideas as to what should be my most important first meeting questions?" My opinion is that you're smart to prepare for this visit. And I actually have a video on this channel. I'll include a card up above and a link down below that talks about what to do to prepare for your doctor visit. So if you haven't seen that, please check that out. Just to make a quick comment, I would make sure to bring hard copies of all of my MRIs, the actual CD-ROM. I would bring copies of my laboratories, particularly spinal fluid. And I would bring notes on each attack I've had, what I took for it, how I responded, and notes including dates of all the disease-modifying therapies I've been on. This is actually super important information for the neurologist, and it'll help optimize that first conversation. But please check out that video because I go into some depth talking about things to do to prepare for your doctor visit. And before we leave, I want to read something that Sonia wrote, which really warmed my heart. She said, "Reading everyone's post, I don't feel as crazy. I was once told that it was all in my head and that I need to get on anxiety medicines. I am so grateful for this group." Well, that makes my day, and Sonia, I'm also grateful for this group. Thank you all for tuning in and learning about MS with me, Aaron Boster. And if you like this video, that's awesome. Please take a moment and subscribe to the channel. And until my next video, take care.